Welcome Dr. Pietro Nenoff. He is from Germany. Welcome to India. And I hope that you are enjoying Pune and our hospitality.
Yes.
Sir, I would like to ask you how frequently you see a superficial fungal infection in your country.
Oh, thank you for invitation and for this interview. My name is Nenoff, as you said, and I'm from Germany. I'm a dermatologist and I'm working in a lab, both in a private lab for microbiological diagnostics and for mycological diagnostics. We are very specialized. And in our office, I see a lot of older people in Germany which are suffering from fungal infections. These are fungal infections of the feet. It means Tinea pedis for dermatologists, and Tinea unguium, what is onychomycosis. And this is so frequent, around 10% of people living in Germany, of all people, are suffering from onychomycosis, and we have a bigger part of older people, and it's increasingly seen. Another kind of infection is Tinea corporis, Tinea cruris, but it's quite others than you see here in India. We have patients suffering from, older patients suffering from Tinea corporis due to Trichophyton rubrum and not to Trichophyton mentacrophytus or Trichophyton interdigitale like you have it here now increasingly in India. And the other part, yes, of patients we are seeing in our offices are children, young people, which have the risk for a fungal infection of the skin and of the scalp, in particular of the scalp, as a Tinea capitis or a Kirian celsi, due to contact to pets at home, or maybe at school, or in the kindergarten, wherever. Yes, we have a lot of pets, maybe rabbits or rodents, and cats, of course, and dogs, which are living together in families at home. And they are carrying fungal agents. It means dermatophytes. These are zoophilic dermatophytes, Microsporum canis, Trichophyton mentacrophytus, and also newer dermatophytes, which are now known maybe for 10, 15 years only. From Asia, it came Trichophyton benhamii, which is a source of infection in Guinea pigs. And we have a lot of Guinea pigs as pets in Germany homes. Yes.
I'm interrupting you. Most of the time, the fungal infections are diagnosed clinically.
Yes.
But what procedure you do to confirm the diagnosis in your country?
This is very
do you do potassium hydroxide mount or fungal culture in each and every patient you encounter in your practice?
Thank you for this question. It's very important. Most of patients will get a mycological diagnostics. It means we take skin scrapings, we take nail material, we take swabs from patients, and we would like to make sure that the patient is suffering from a fungal infection. And in the lab, or maybe in the dermatological office, we are dealing with KAH preparation, or maybe a variation of it, which is much more sensitive. This is a fluorescence optical preparation, chalcofluor. It's also known here in India. Second basis of fungal infections diagnostic is culture, cultivation of the material to find the growing dermatophytes or maybe yeasts or molds. This is a common regular diagnostics. But what is increasingly done in Germany, maybe in the last 2-3 years, and it's very important now, is a molecular diagnostics. It means we try to find the DNA of the fungal agent of dermatophytes directly in the clinical material, what means in skin scrapings, in hair roots, or maybe in nail material. It works very fast, very sensitive. This is a PCR diagnostic, real-time PCR diagnostic, or the highest level we will get by sequencing of the DNA of the fungal agent, and so we can have a very specialized diagnostic.
Dr. Nenoff, my question is, do you wait for this diagnostic test to become before starting the treatment, or you start the treatment after taking?
This is a very important question again. Yes, to be realistic, of course, in Germany also. We have a lot of colleagues, dermatologists, they do not wait. They make the diagnosis on clinical picture, and they say, now I treat empirical. Yes, it's empirical treat because they have experience to say this is a fungal infection of the skin or of the nail of the scalp. But the biggest part of dermatologists is using a mycological diagnostic, a laboratory diagnostic, and they are waiting. First, maybe they are preparing KOH preparation. If this is positive, they are starting by topical therapy, topical antifungal therapy, and if the culture is positive, or maybe the PCR is positive, then they are starting by oral
So what
antifungal
topical
therapy.
therapy do you prefer in your patient?
For topical, yes?
What topical therapy do you prefer in your patient in Germany?
In Germany we have a lot of azoles, but maybe more the older azoles, what is miconazole, this is my favorite, and clotrimazole, which is also my favorite. But we are very, very frequently are using cyclopirox as cream or as
Do you think
solution.
miconazole or clotrimazole works in your patient? Because here in India we encounter that these two older generation azoles are not even working in many of our patients.
Yes, at the moment we have the good situation that these topicals I have mentioned, they are working good. But the problem may be in the future, and it started now, we also have these terbinafine-resistant dermatophytes which are available here in India, and first patients are to be seen now in Germany also, and we will see what happens there. But at the moment, the older azoles and the amorolfine shows very good results for topical treatment. Yes, or both in tinea corporis, tinea pedis, but also in onychomycosis as nail lacquer.
What about luliconazole?
Yes, I know it, of course, because I'm familiar with Indian dermatology a little bit, and I know it is very effective against the T. mentagrophytis genotype 8, which is prevalent in India, but we don't have it in Germany. It's not approved in Germany for use in medicine. Until now, we are waiting for luliconazole. Yes, it would be nice to have it.
Now, what about the systemic antifungal agents you use in your patient? When you think that the patient requires systemic therapy when it is extensive, or patient is suffering from tinea incognito or mycosis granuloma?
Yes, I am a fan of oral or systemic antifungal therapy. And in particular, patients with onychomycosis, you have to treat them by oral agents. And the therapy of choice at the moment in Germany is terbinafine. Yes, 1 tablet a day for 3 months, or maybe longer if there's no good therapy response. Second choice is fluconazole. Fluconazole, we have also good results in dermatophytosis. And the third choice is itraconazole. Yes, we don't have griseofulvin. It's not longer available in Germany. This is a little bit pity, but we have to deal with this. And,
what doses of itraconazole is available in your country?
Itraconazole?
Itraconazole.
We are using itraconazole for adults. It's approved, but it's not approved for children.
No,
for
in our
people.
country, it is available in the strength of 100 milligram, 200 milligram, and even some companies have come out with the 400 milligram.
Yes.
Sustained release tablets.
Yes, I have learned in India that the only way to treat these chronic recalcitrant dermatophytosis due to T. mentagrophytis genotype 8 by itraconazole 400 milligram per day. This is an off-label use also here in India for 4 weeks, maybe 8 weeks, and it seems to work. And we have first patients in Germany with the same Indian fungal infection, and we are using it also 200 milligram or 400 milligram per day itraconazole for 4 weeks or maybe longer. This is the only way to treat these patients at the moment, and we have to speak with the patients, and we will get their agreement, and we have to do it. Yes.
Okay. My next question is, what about the older generation griseofulvin antifungal agent?
Yes.
What is your comments on it?
In Germany, it's not so common in the last maybe 10 or 20 years. We had not so much children suffering from dermatophytosis of the scalp, tinea capitis or Kerioncelsi, and so it was used very, very rare only. It resulted that the company said it's not longer useful in Germany and we don't sell it, and it's not available in Germany now. And we have to treat patients without grisifulvine. But I know.
But what about the Kerion? You said that the tinea capitis and Kerion.
Yes.
What do you prescribe in these cases?
If we have a zoophilic infection, maybe T. mentagrophitis is zoophilic strain in Germany, we can treat it very good by terbinafine, but it's off-label use. Yes. Second choice is itaconazole for Kerioncelsi. Yes, and we don't have grisifulvine, and we don't need it at the moment because we don't have resistance at the moment, but it can change.
In our country, India, many of the families are affected. The members of the family, 3-4 members of the same family is getting affected. What is your comment on this? Do you encounter such kind of clinical situation in your country?
At the moment, we only have single patients and couples maybe which are affected within one family, but this is a rare scenario at the moment. But in India, I know it, of course. This is a terrible spread of this fungal infection. But I see the reason why should be the use of these cocktail creams containing clobetasol, and this should be stopped in India. There should be find a way to stop this. And the other way is to look for patient's immune system. Maybe there are some disturbance. They have a predisposition for these fungal infections. We don't know it at the moment, yes. And we have to initiate a lot of research on this field, yes.
What about the special situation like fungal infection in pregnant women?
Yes. Yes, in Germany, our treatment regime is to treat the pregnant women only topically. We don't treat pregnant women orally, yes, only very, very rare. And if we are using itaconazole. But I know India, we have a lot of pregnant women, patients suffering from these recalcitrant fungal infections. And yes, this is an off-label use to take oral antifungals. And I have heard in India they are treating by terbinafine, maybe other oral antifungals. But in Germany we are waiting for the time after the pregnancy and after lactation, and then we are starting maybe in onychomycosis in a formerly pregnant woman, and then we...
So it's better to defer the treatment till the delivery, and then you can go for a systemic therapy.
Yes, this would be my advice, yes.
And you want to prescribe topical treatment in pregnant women.
Yes, yes.
What about the elderly people, like the people who are above 70 years of age?
Yes, we have a lot of them.
Yeah, what do you think? It's a topical or systemic or combination of both?
It depends from the willing of the patient. If he has an onychomycosis, tinea pedis is very affected, then and he had the will to be healthy, and then I treat all these patients orally by terbinafine, by itaconazole or fluconazole with onychomycosis. Yes, okay. But in older patients, you have a lot of other drugs they are taken. Yeah, and it's a little bit dangerous maybe for interaction between antifungals and other medications, maybe lipid inhibitor or whatever. And you have to be aware that there's no interaction. But if there are other drugs, we are using a low dose treatment, with what means 1 tablet a week only. 1 tablet of terbinafine a week only for a long duration in these older patients. And it seems to work in onychomycosis. Yes, this is interesting, but we don't have good studies on this. Yes, it's an off-label use.
Okay. What about the fluconazole in elderly patient?
Yes, there's no problem. I believe so. Yes.
What doses you prefer?
In tinea corporis, 50 milligram per day, 50 milligram only per day for maybe 4 weeks. In onychomycosis, we are using fluconazole as an 1 weekly dosage only. It means 150 or 300 milligram once a week only.
For how long?
Oh, that's a good question. For 9 months, maybe 12 months.
So
yes,
we use
a long
6
time
to 9
treatment.
months.
Yes,
6 to 9 months.
yes.
So what is your advice to us or
Yes.
your experience in treating fungal infection, if I say to summarize in 1 or 2 sentences?
It's exciting and it's horrible that fungal infections are absolutely increase to be seen, and not only in India but in a lot of other countries, and we should be aware, we should make a lot of research on this field as dermatologists to find solutions for this absolutely big, great problem.
Thank you.
Okay, thank you again also.